Okay, so yeah, there is going to be the lab quiz number 3 that you have to complete by tomorrow. I mean, it's not super hard, right? Just like the other ones. You still have 2 days to do it, so that should be pretty sufficient time. Um, it is going to be, sorry, it is going to be on the unit 3, but also it's going to have questions about those microscope slides that we have done throughout the entire course. Okay, so like you might see a slide with like the lungs and the alveoli and stuff like that. And I would ask you to identify what it is. So the best way to prepare for that is to just look at all those online lab PowerPoints that you've done, and just go through all the microscope slides and be able to identify them, okay, before you write the actual lab quiz. That is going to be 5%. So unlike the other ones, which is like 2.5 each, this one is worth a little bit more, just because there's more content in it. But in terms of difficulty, it's not that much more difficult, relatively speaking. And then Wednesday you will do your final test, and that's it. Okay, that is it for the course. Now I don't know if you had a chance to look at the review yet, but that's what we're gonna take up today. Okay, so first question, give 3 examples of long bone. Right, so we know we can classify bones based on their shape. There's long bone, there's short bone, there are irregular bones, right? Flat bones. So this question asks us to give 3 examples of long bones. So I'm just going to write some generic answers here. We have the femur, right? We have the humerus and the metacarpals, for example. People tend to do quite well on the last test, the class average for the last test, despite having more content to it. Well, not more content, but like it's more involved, right? For all these bones and hormones and stuff like that, people tend to do much better on the last test. So, in case you're worrying about it, hopefully that gave you some comfort. Okay, next part. List 3 types of movable joint and list an example of each. Okay, so I mean, we have 6 examples of movable joints, right? Just gonna put 3 here: ball and socket, that would be like the shoulder. So at the shoulder, we have the head of the humerus, which is going to be inserted into the glenoid cavity of scapula. The scapula is your shoulder blade, right? Okay. And then we have the other ball and socket, which is in the hip. So that would be the head of femur into the acetabulum of the coxal bone. Okay, we'll review about the coxal bone later, but you probably remember it has 3 bones to it, right? There's the ilium, the ischium, and the the ilium, the ischium, and the pubic bone. Number 3, list all bones of the arm from most proximal to most distal. So, let's just draw a picture maybe. This is anterior view. okay, of the left arm, right? So this is the scapula. And that's the glenoid cavity I was talking about. And of course, your humerus, right? Humerus is going to be here. Distal to the humerus, you have two bones, right? We have the one that is on the lateral side, that will be the radius. And the one that's on the medial side, that's going to be the ulna. Okay? The elbow is a hinge joint between the humerus and the ulna, right? We have some smaller bones here, right? That makes up the carpal. And we have 8 of them. So the carpals. And then distal to the carpals, we're going to have the metacarpals. Okay. And then you have your finger bones, which would be the phalanges, right? Only 2 for the thumb and 3 for everything else. 14 phalanges. Okay. So those are the bones of the arm from the most proximal to the most distal. Okay. Next one says list all the bones of the legs from most proximal to most distal. So basically it's the same question but for the leg. I'm just going to draw it next to it so you can compare it. And so we have the this would be the pelvic girdle, and the socket on the side is acetabulum. We have the longest bone here in the body. That would be the femur. Okay, we have the patella here, which is the kneecap. We have the main weight-bearing bone in the middle. That would be the tibia. And on the side, right, on the side we would have the fibula. And this whole thing is just going to be resting on the talus. Okay, so talus is one of the 7 bones of the tarsals. Okay, so like analogous to the carpals, you have the tarsals at the foot, and the talus is one of them. Okay, and then you have like a few more bones here that we don't have to know the name. They're also part of the talus. Tarsals, I mean. And you're going to have a heel bone at the back. This is called the calcaneus. And, you would have your metatarsals. Okay. And again, like all these things, right? All these things along with these small bones, they are the tarsals. And you would have the phalanges again. Okay, so I mean, just familiarize with your bones. There are going to be some questions like, it's pointing to a structure and then asking you what bone are you like is a picture pointing at, those kind of things. Should be pretty straightforward. All right, next one here. List the different sections of the vertebral column and the number of vertebra corresponding to each section. So we have the cervical, 7 of them, thoracic, 12, lumbar, 5, sacrum, just 1, and we have the coccyx, which is tailbones, right? It's like 3 to 5 fused together. Okay. A lot of these are just like old stuff that we talked about. Nothing too difficult here. 3 parts of the sternum. Sternum is the chest bone, which is right in the middle. We have the manubrium. That's where the first and the second rib is going to connect to. We have the body. And then at the end, we have the xiphoid process. That is for the diaphragm to attach to, right? Okay. How are ribs classify? Explain the difference. So we have 7 pairs of true ribs. And what makes them true rib is that they directly connect to the sternum. Through costal cartilage. They have their own, right? And then they're just gonna connect it that way. And we have 5 pairs. 5 pairs of false ribs. Okay. Of the 5 pair of false ribs, the last 2 pair, right? Last 2 pair are floating ribs. So the number 8 to number 10, those are the ones that will indirectly connect to the sternum by attaching to the costal cartilage of number 7, okay, before going to the sternum. And for the floating ribs, they don't attach at all. Okay, there are no costal cartilage. They're just kind of, as the name implies, right, just floating there. Okay, so we labeled this already. You can go back and refer to the diagram to see better. Okay, next one. Name all the bones and the features of the pelvic girdle. I just have a picture here that we can use as reference. We did this already as well in the study guide, but it's good to go through them again. So the red stuff here, it's called the hip bones, but we actually call it like coxal bones, right? In class. So just call it like 1 here, maybe 2 and 3. So coxal bone equals to 1, 2, 3 together. 1 is the ilium. Number 2 is the pubis. And number 3 is the ischium. Right? At the back, the ilium is going to make an articulation with the sacrum. And at the front, where the pubis join together, there is a symphysis pubis. Like a little bit of cartilage. There are other features here, right? Where's that opening? That is the obturator foramen. Okay, allows blood vessels and nerves to pass through to the legs. So we're not gonna damage it when we are sitting down. There is this socket that we have been talking about all day long already, right here. That is the acetabulum. Right, ball and socket joint, right, with the femur. You should know that by now. There is other landmark like the iliac crest. There is the ischiotuberosity, right, where we're sitting on. Okay. That's pretty much it. Do you guys have any question? Sorry, I sound very, very out of it. Like,
Can you zoom out a bit?
yeah. There you go. I'm not as enthused as I normally are, but hopefully we'll get through this. Okay, so that's that. Next, name all the bones that forms the different sides of the eye socket. So here they are, conveniently. I found a diagram that has all the bones in it already. Now you should know that there's just one frontal bone, one sphenoid bone. Okay, the zygomatic, right? That's gonna have like two bones, one on each side. You have a maxilla, palatine bone, right? Ethmoid bone is also one, necromal is two. So 1, 2, 3, 4, 5, 6, 7. Those are the 7 bones that forms your orbit. Right? And you should know which one is on the side, which one is on the medial side, lateral side, superior, inferior. Okay. So there's going to be a question like, select all the bones that forms your eye socket or something like that. Okay, those multi-select questions, right? Okay, next one. This bone forms your heel, which is just this one at the back. That's the calcaneus. Okay, calcaneus. It's one of the tarsal bones that you have. You have 7 tarsal bones in the foot. Next, this bone connects to the distal end of the tibia and the fibula. That would be the talus. It's right here. The talus. Okay, so like the tibia and the fibula clams on it on both sides, and it forms like the ankle, right? I will of course post this afterwards, so like, if you need some of these pictures, it'll be there. Okay, this bone protects the pituitary gland. We know it's the sphenoid bone. And there's a groove at the top side for the pituitary gland to sit in, right? Okay, that's it for the bone unit for now. I mean, actually, is there more stuff? I don't know why this is here. The sperms, the reproductive stuff. I think there's also more bone stuff coming up, right? Yeah, let's skip to the other bone stuff first. This thing is, I should probably update it. 18, right? Function of skeletal system. So things like, provide support for the body. Hematopoiesis, production of new blood cells from the bone marrow, right? Mineral storage, not just calcium, but phosphate as well, right? And allows movement. When the muscle pulls on it, you move, right? Protection of organs. We did this already. We're not going to do that again. Describe the structure of compact bone. You should know the different parts, okay? Like I might give you a picture and ask you to identify it. We did that very elaborate picture of compact bone, right? So maybe just go through it again yourself, but here's the gist of it. This is the osteon, right? Which is the structural unit of your compact bone. The material that makes up the osteon is the lamina, right, which is the calcify matrix. That's the part where you store the minerals, right? You have the calcium salt and the phosphate salt. Now, there are these little pockets that are everywhere in the osteon, right? And there are these lines that are coming out from the pockets, right? The lines are like basically cracks in the bones that allows the bone cells to be moving around and blood vessels to transverse. And so, these black dots, they are the lacunae. That's where you will find the osteocytes inside. These cracks are called caniculus. Which again allows the bone cells to move around, right, in the bony matrix. And here is the blood vessel. Here's the blood vessel that will be coming out from the central canal. I mean, those are the key features, and you should be able to identify them. I think there was a picture in lab number 3 as well. That like shows you like an actual bone slide. You should go through that and make sure you can identify the real thing. Okay, this one is a PTH and calcitonin. We should go through that as well. You have to like be careful when you do the question on the test, because the trigger, the stimulus, and the effect are often opposite to each other, right? So you have to read it carefully and see whether the question says, for example, if the question say the stimulus for this hormone is high blood calcium level, okay? Stimulus is high blood calcium versus this hormone increase blood calcium level. Okay, here. Let me rewrite this again. I'm very sorry. Like I know I sound, I'm like my thoughts are like going all over the place. So sorry. Stimulus is blood calcium level increase. Okay, so I'm trying to tell you, if the question says the stimulus for this hormone is blood calcium level increase. Okay, so that means you have too much calcium and you want to bring it down. That would be like calcitonin. But if the question says this hormone increase blood calcium level, then it's actually talking about PTH, right? Because you have PTH in your system when you don't have enough blood calcium. Okay, so like you need to read to see whether the increase in calcium or whatever it happens to be, increase in glucose or whatever other hormone we're talking about, that the question is telling you about the stimulus or telling you about the effect, because the answers are very different, right? Do you guys understand what I'm trying to tell you here? Any follow-up question? Okay. So in that regard, it's probably a good idea that we quickly go through the calcitonin and the PTH. Okay, so if you have increasing calcium, blood calcium, of course, then thyroid gland releases calcitonin, which will then lower calcium by depositing calcium in bones and reduce calcium absorption in kidney. Okay. If you haven't already, you should have created your own booklet for all the hormones we've learned, right? I know I didn't fill in that chart with you for lecture 12, which has all the hormones in it, but you must do it yourself, okay, and have it handy, right, for reference when you're doing the test. Okay, it's going to help. On the other hand, if you decrease blood calcium level, the parathyroid gland will release PTH, okay, and that will increase calcium in the blood by increasing absorption from bones, kidneys, and intestine, right? And remember, to do that, it would be through vitamin D activation. Okay. I don't know why this question is here. Just gonna delete it. The function of parathyroid hormone is to increase calcium in the blood, right? Like we just talked about that, right? Okay. All right. Let's let that. I mean, that's it. Yeah, that's it for the bone unit, I think. Let me see. Okay, so There are some reproductive questions here, but I think it's excuse me. I think it's being repeated here. Okay, so let's just do this here first. Here it says the semen is a combination of sperm and various secretions. Name 3 glands that contribute to the secretion and describe type of secretion of each gland. Okay, so we have the seminal vesicle. You have 2 of them. And this secretes a fructose-rich alkaline fluid. Okay. What's another gland here? Prostate gland. This is again another alkaline fluid to enhance sperm motility, allows them to move better. And then there's one last one here, which is the bulbal urethral gland. I flush the urethra to neutralize acidic urine. Okay. Now, just to give you like a path, right, for the sperm. They're of course made in the testes, and they will continue to mature and be stored at the epididymis. Okay, and then when they're ready to come out, they're gonna have to go through the vas deferens. Okay, the vas deferens will go through the prostate gland. Okay, and before that, the seminal vesicle will add its content. And then from the prostate gland, it will merge with the urethra, but not before the bulbal urethral gland adds its content. Okay. Our next part here, 23. Describe the effects of LH and FSH on male and female reproductive system. LH for female. I mean, we did a hormone chart on this, right? But basically, for LH, it is going to trigger ovulation. Right, and ultimately increase progesterone. That's for female, and for male, it is going to increase testosterone. Okay, so this is female. This is male. As for FSH, it is going to basically, for female, is oogenesis, right? Follicle development. increase estrogen. And for male, it is basically spermatogenesis. Okay. I mean, we have a more detailed description of this in the hormone chart of lecture 11. Okay. Here we can draw a picture to summarize all this stuff. Okay, the relationship, right? So at the beginning we have increase in GnRH. That's the beginning of the cycle, and then that will lead to increase in FSH, right, and LH. FSH is dominating in the first part of the cycle. We know that, and it's going to develop the follicle, which leads to increase in estrogen. Okay. Of course, this is from hypothalamus. This is from anterior pituitary gland. And then the estrogen will thickens the endometrium. And also, at the same time, it's going to go back and have this positive feedback, right? So this is all during the follicular phase. And then second time, when you have more GnRH and then, more LH, then that's going to lead to ovulation. And then the corpus luteum form, which will increase progesterone, right? And then progesterone will further thicken the endometrium, but at the same time, it will go back, right? And it will suppress GnRH and FSH-LH production. This is negative feedback, and that's going to be happening in the luteal phase. Okay, so that pretty much sums up everything that's happening, right? Okay, number 25. Individuals with higher than normal level of FSH might be more likely to have non-identical twins. Explain why. Higher FSH level might result in more than one follicle being developed per cycle. Okay, so if 2 eggs are being released, then there is a high chance for 2 fertilizations. Yeah, and that could lead to non-identical twins, right? That should make sense. Describe the interaction between the hypothalamus and the pituitary gland in very simple sense. I mean, we spent quite a bit of time talking about this, but like, if I have to summarize it in a simple sentence or two, hypothalamus produces ADH and oxytocin, which are stored and released from posterior pituitary. On the other hand, how do I get more space here? Give me a second. On the other hand, the hypothalamus regulates AP hormone secretion through things like GnRH, TRH, and CRH, right? Through releasing hormone as well as inhibiting hormone, which we did not learn. Describe the differences between the cause of type 1 and type 2 diabetes. I think we never went through this in class. I mean, there was a couple slides for it, but then I think I was like, oh, let's do it on Wednesday, but then I never came on Wednesday, right? Last week. So let's just briefly talk about it. So type 1 is usually called the juvenile form. In this case, pancreas cannot produce insulin. Okay, like the most common reason for that is autoimmune disorder. Your immune system attacks the insulin producing cells in the pancreas. Those are the beta islet cells. And without insulin, the person cannot absorb the glucose. Okay, so like these people would have high blood glucose. Right, like after a meal, the glucose doesn't get absorbed into the cells because there are no insulin, and therefore they would need to have insulin shot. Okay, if they don't have insulin shots, they basically will be starving on a cellular level. Okay, the body will think that it's starving, and then will start to burn other fuels. Okay, proteins, lipids, and all that stuff. But that's not going to help because burning those fuels, will further increase the glucose level in the bloodstream, and then without the insulin, you still won't be able to absorb it. Okay, so this is something that is common in usually in kids, although sometimes it's possible to happen in adults as well. Okay, type 2. So like this is like low or no insulin, right? On the other hand, type 2 is something that you get later on in life. I mean, not later on, but like it's not something that you're born with, okay? And this has to do with lifestyle sometimes, right? Eating habit, right? It's linked to obesity. Okay, so like your body becomes insensitive to insulin. Okay, so this would actually have high insulin in the blood. Okay. So your body is not responding well to the insulin, because there are like constant high sugar level in the blood, and then your pancreas makes more insulin to try to absorb the excess glucose, but eventually your body just doesn't respond well to it anymore. Okay, so in this case, it won't help if you give the patient more insulin shots, okay, because they're just not going to respond to it. So the therapy aims at lowering blood sugar level, okay, by changing lifestyle, like becoming more active, watching what you eat, right? Or have medication that would aim at reducing the blood sugar level. So that's a difference between type 1 and type 2. Okay, this is more like something that people are born with, not making insulin. And here you're making insulin just fine. In fact, you're making too much of it. The problem is your body's not responding to it. Okay? I think that's all you have to know for the purpose of a test. Okay, give examples of negative feedback loop. I mean, we have a lot of examples of that, right? I think we're going to be seeing a few charts coming up, like the HPA, right? There are examples of negative feedback, right? We'll fill those in a bit. Describe in detail how insulin and glucagon work together to maintain homeostasis. And so, increase glucose, then the beta cells in pancreas release insulin. Okay. And then it will promote cell absorption of glucose. Okay. And liver will convert glucose into glycogen. Okay. Fat cells also converts glucose into fat. On the other hand, if you have low glucose, the alpha cells in pancreas release glucagon, and in this case it's basically the opposite. Okay, so liver converts glycogen, the storage form, into glucose. Okay, and if you are experiencing low glucose level for prolonged period of time, then the fat cells will also convert fat into glucose. Okay, like this usually doesn't happen right away. Like you have to be starving for, maybe a few days before your body does that. Like it's like you usually tap into your short-term storage reserve before you go into your long-term storage, right? Oxytocin and prolactin. So oxytocin is for letdown of milk, for the milk to come out, and prolactin is the production of milk. Oxytocin is released from the posterior pituitary. Prolactin is released from the anterior pituitary. Right, again, have that chart, right? In lecture 12. This chart. Right? That just summarizes all the hormones that are coming from all the glands. Have that ready. Okay, describe the role of thyroid in maintaining homeostasis. That's basically the T3 and the T4, right? Maintaining the homeostasis of metabolism. I think these loops is going to help explain that. Okay, so let's see. We have the hypothalamus. This is for male reproduction, right? Which we know it's going to release the GnRH. And then anterior pituitary gland will release the FSH and the LH. Those will act on the testicles to produce testosterone, which will positively reinforce spermatogenesis. But if you already have adequate level of testosterone, it would be important to go back and suppress the hypothalamus and the AP so we don't have excess amount of testosterone. Okay. Female reproductive system, it's very similar. We already did that already, like earlier, right? But you know what? It's okay. Let's just do it again. GnRH. Okay, we have FSH here and a little bit of LH. And then that's going to go to the ovaries to develop the follicle. As the follicle develops, you're going to have the estrogen, which will thicken endometrium. They're going to go up here for positive reinforcement. Okay, so like most of the regulations are negative feedback, right? You should know that by now. And we only learned 2 examples of positive feedback, right? Oxytocin and this estrogen regulation during the follicular phase. This is another one for the female. Right? We have the GnRH. FSH, LH again. It's going to go to the ovaries. And then it's going to basically trigger ovulation. And then we're going to get the progesterone, which will thickens endometrium again in preparation for pregnancy. But this time we will have negative feedback because the egg is already in the fallopian tube. There's no need to develop another one. Metabolism. Hypothalamus release the TRH, which acts on the anterior pituitary gland to release the thyroid stimulating hormone, which will then go ahead and stimulate the thyroid to release T3 and T4. That will increase the metabolism. Okay, and then we're going to want to shut it down. Otherwise, you're going to have too much, right? T3, T4 causing metabolism to become out of control. We talked about hyper and hypothyroidism. You probably want to review that on your own. I'm not going to do it again here, but you should know the difference. Here, let me give you a question to do. Okay, so take a look at this question. I'll just make it bigger for now. Which of the following is the most likely explanation for hypothyroidism in the patient whose iodine level is normal? So in class, right, I told you there are different causes for hypothyroidism, and iodine deficiency is one of them. If we don't have enough raw material to make T3, T4, you're gonna have low metabolism. So this question is saying, what if the iodine level is normal, but the person still have hypothyroidism? Which of the following is the most likely cause? Here, let me launch the poll for you. Okay, I mean, has been 2 minutes, but I only got 3 people trying. Thank you. Anyway, so we're supposed to only choose one answer here. So normally, right? Look over here, right? To have T3, T4, I need to have TRH and TSH, right? So here it says hypo secretion of TSH. What does hypo secretion mean? Hypo means like low, right? So in other words, this means low TSH. So look, if you have low TSH, then you're gonna have low T3, T4, right? Okay, that's the answer. That's the answer. Let's see why some of the other ones are gonna be wrong. Hyper secretion of TSH. If you have high TSH, you're gonna have high T3, T4, right? Then that wouldn't be hypothyroidism, it would have been hyper, right? In fact, like if this is true, this one cannot be true, right? A decrease in thyroid secretion of calcitonin. Calcitonin has nothing to do with metabolism, so I'm glad nobody chose that. Hyper secretion of TRH. Look, if you have high TRH, the next thing that's going to happen is high TSH, which means the next thing that's going to happen is high T3, T4. But we have hypothyroidism, so that's not going to be the problem. Disproportionate production of T3 and T4. They actually do the same job. It's like a safety mechanism. Okay, so like if you don't have enough T3, no problem. T4 will take over. Okay, if you don't have enough T4, again, no problem. T3 will be able to compensate. So, you know, even if you have disproportionate production of these things, like one high, one low, it's not going to cause hypothyroidism. It's when you have both of them that are low, then that's going to be the problem. Okay, so the answer is hyposecretion of TSH. Does anybody have any question about that? No? Okay. Yeah. So that is that. Let me see if I give you another one here. Which of the following is or rare? Sorry, is or are correct for hyperthyroidism? Hyperthyroidism. Okay, so metabolism is going to be high. Right, could result in goiter. TSH level is low, which makes sense because if you have a lot of T3 and T4 in hyperthyroidism, they're gonna suppress the TSH, right, through negative feedback. T3 and T4 levels are low. That's not true. It's going to be high. And TRH level is also going to be low because of the negative feedback, right? Okay, so only the first three are correct. All right, that's that. Hopefully these helps. Stress, we talk about the cortisol, right? The long-term stress. So we're gonna have the CRH. Then it's gonna stimulate the anterior pituitary gland to secrete the ACTH. And then it's going to act on the adrenal cortex. That's the part for long-term stress. Immediate stress is from the adrenal medulla, right? It's going to cause you to release the cortisol, which will increase resource availability. Okay, so normally it's going to go back for negative feedback, but if you are chronically stressed, then your nervous system will override these negative feedback, right? And then it will cause your cortisol level to go very, very high. Okay, this table summarizes the 3 pairs of antagonistic hormones. Okay, so let's just fill them in with different colors. So let's say we're looking at normal levels of sodium in the blood. So increased level of sodium, what's going to happen? Well, it's going to cause you to release ANH from the heart. And then it will bring the sodium level back down. Okay. We don't have to worry about the how, because I mean, the ANH is part of the kidney unit, kidney lesson anyway. The kidney lesson is not on that test, so you don't have to really worry about it. A decrease in sodium is going to release the aldosterone, which will bring the sodium level back up. The other one is calcium. So if you increase calcium, thyroid is going to release calcitonin, which will bring the calcium level back down. If you decrease calcium, you will need PTH to bring the calcium back up. And then the last one is the glucose, right? So if glucose goes up, then we need insulin, which brings glucose back down. If glucose goes down, then we need glucagon. Both are from the pancreas, right? The beta cells and the alpha cells. And we're going to bring the glucose back up. Okay. So I like creating charts like these, especially because like I said, right, if you go into nursing program, you're going to learn all these things again, and you have to memorize it by then, right? So having a chart like this to just organize the information really helps me anyway, really helps me memorize, some of these hormones, because there are 20 of them, right? Okay, so we have a bunch of multiple choice here. Let's just, let's just go through them, okay? Which endocrine glands are located in the abdominal cavity? Okay, so not the first one, because thyroid gland is all the way up in the neck, right? Pineal gland is in the brain, so that's definitely not it. Adrenal gland and ovaries. Ovaries are further down, right, in the pelvic cavity, right? So that's not it. So it's the pancreas and the adrenal glands. Okay? If you want to try these questions on your own later, you can just copy the answer on a piece of paper first, right? or maybe you've already tried them. I don't know. A decrease in blood sodium level stimulates the release of the hormone aldosterone from the adrenal cortex. This is an example of hormonal control. Okay, example of nervous control would be like epinephrine, right? Like it's really quick, right? It's from the sympathetic system, right? So even though the ultimate result is a release of a hormone, but it's done through action potential rather than action of a hormone. The hypothalamus controls the anterior pituitary gland by producing, releasing hormone and inhibiting hormone, right? We talked about that multiple times already. GnRH, TRH, CRH. It's just that we didn't learn any inhibiting hormone. Right? We didn't learn their names, okay? But know that they're there. Which of the following is not true concerning oxytocin? Okay, so this is the hormone that is made in the hypothalamus, but stored and released from the PP, posterior pituitary, and is responsible for uterine contraction and milk letdown. So oxytocin increased uterine contraction during childbirth. That's correct. Nothing to change there. Oxytocin produces milk letdown during nursing. That's also true. Now, if they say produces milk, then that's wrong, right? Okay, what hormone produces milk? It's not the oxytocin, is it? It's the prolactin, right? Okay, so you gotta be careful. Produces milk letdown. It means like let the milk come out, basically. Oxytocin is produced by the posterior pituitary gland. That's not true. It's the hypothalamus, right? Okay, and this is controlled by positive feedback. Yep. Right. The more contraction you get, the more oxytocin you will have. Right? Number 5, which of the following hormones will affect another endocrine gland? So basically is talking about the hormones that will act on one of the glands that is on the list. So TSH, of course, it stimulates the thyroid. So that's it. ACTH stimulates the adrenal cortex. That's also it. Right? These are tropic hormones, remember? Gonadotropin releasing hormone, that is from the hypothalamus, but then it acts on the anterior pituitary gland, which is also another endocrine gland. So the answer is all of the above. Number 6, the pituitary hormone ACTH will stimulate the something to produce its hormone. AC is adrenocortical tropic hormone, right? So it stimulates the adrenal cortex. Which endocrine gland produces the greatest number of hormones? Okay, so it would be the anterior pituitary. From posterior pituitary gland, it doesn't produce anything. It just stores the one from hypothalamus. Anterior pituitary, right? There are the 4 tropic hormones plus the GH and the prolactin. So that's a total of 6. Thyroid gland, right? It's calcitonin, T3, T4. Adrenal gland, we have the epinephrine and the norepinephrine from the medulla, and then we have the aldosterone and the cortisol, right? From the cortex. Okay, so what is that? 1, 2, 3, 4. So AP is the most. What is the target organ of thyroxine, which is T4, right? So it targets most bodily cells, increases the metabolism of all of them, right? No specific target. The function of T4, I just told you that, increases metabolic rate. Stimulates kidney to reabsorb water, that would be ADH, since we're doing it, might as well. Raises blood sugar, that would be glucagon. Stimulate protein synthesis, irrelevant. Which hormone is needed for thyroxine production? Right, TSH, right? Thyroid stimulating hormone will stimulate the thyroid. to make it. Which of the following is not a target organ for parathyroid hormone? Parathyroid hormone is going to bring the blood calcium level up by absorbing it from bones, intestine, and kidneys. Muscle is not a target. Which of the following is not true of glucocorticoids? Okay, the main glucocorticoid is the cortisol. And so what does it do? Promotes the metabolism of fatty acids instead of carbohydrates, right? That's a correct one. Okay. I mean, that's true statement. I remember I said it saved the good stuff for the brain, right? The glucose during long-term stress. Promote kidney absorption of sodium. That's not the function of glucocorticoids. That's the function of aldosterone, which is also from the same endocrine gland, but different hormones. These two are also functions of cortisol. Cortisol, let's see, reduce inflammation, pain, and swelling. That's true. Right? Remember I said the acne cream that people use, maybe, right? Or lotion, the cream for eczema, that kind of stuff, contains cortisone, which is a type of cortisol, and it reduces inflammation, pain, and swelling. May be used to treat arthritis, even though I didn't specifically tell you it does, but itis is inflammation, right? So if it reduces inflammation, it's good for reducing, some kind of inflammation. May suppress the immune system. That is also true, right? Because by reducing inflammation, you're essentially suppressing the immune system. So the answer is all of the above. Insulin results in most cells taking up glucose. Yep. Fat cells making more fat. That's also true. Converting glycogen into glucose. It should be the other way around. So the answer is D. It's both A and B here. Okay, we're almost there. What is the stimulus for releasing insulin? If you have high blood glucose, right, after a meal, right? Target tissues for glucagon. We're going to target the adipose tissue and the liver. What is the stimulus for the release of glucagon? That is when you have decrease in blood glucose level. There we go. When you are fasting, when you're skipping a meal. Something stores sperm and allows them to mature. That's the epididymis. The bulbourethral gland is not part of the male duct system because the sperm actually don't go into it, right? Doesn't pass through it, right? Think of it like the accessory organs of a digestive system, right? If it doesn't pass through it, then it's not part of the duct system. The vas deferens joins a duct from the seminal vesicle to form the ejaculatory duct. You can see the diagram that we labeled before. The ejaculatory duct joins, this is like the same thing, it's just, further down, joins the urethra in the prostate gland. Which gland secretes mucus-like fluid that helps lubricate the end of the penis for sexual intercourse? That would be the bulbourethral gland. So it flushes the urinary tract, then lubricates the penis. Number 23. Which of the following stimulates spermatogenesis in the seminiferous tubule? That would be FSH. Development of fetus occurs in the uterus. The female is pregnant when, okay, so we test for the HCG, right? That's the hormone we test for to see if someone's pregnant. And the function of the HCG is to help maintain the corpus luteum until the placenta is fully formed. Right? Remember, the corpus luteum is the one that's cranking out the progesterone, and we need the progesterone to maintain the thickness of the endometrium. So we need that. We don't want the corpus luteum to break down, and that's what the HCG is going to do. Right? Until the placenta forms, then the placenta will take over and make its own progesterone. So that's good. But keep reading on the test, right? It's used to detect pregnancy. Told you that's correct as well. And it keeps a new follicle from developing, right? Which makes sense. You're already pregnant, right? You don't need another follicle at this time. Like there's no period, right, during pregnancy. So the answer is all of the above. And that's it. Okay. I apologize. It was not the best lesson, but like I told you, I'm still not feeling very well. I'm trying my best here. If you have any additional question, please feel free to email me, whether it's about the lab or about the the final test. And that's it. I won't see you again. I'll post your grades when the test is done. And like I told you before, if you need anything from the course shell, please download them. And in the future, if you need just like something, you can always contact me as well. If you need like a reference letter or whatever like that, that you need in your next program, just feel free to email me. Other than that, thank you for taking the course, and I wish you all the best with all your exams. Bye for now, guys. Take care.